of these. And this one tonight is on COVID-19, what is happening and how is Marin responding? I'm very excited to present our panelists. We've got three panelists that are going to be talking with us tonight. We have Dr. George Rutherford, who's a professor of epidemiology and biostatistics at UCSF and the director of the Prevention and Public Health Group. His research interests are in epidemiology and prevention of infectious tropical diseases of public health importance, both internationally and domestically, with a primary focus on HIV and AIDS. Dr. Matt Willis is our county's public health officer, and he's been the public health officer since 2013. He is a Marin native, and he lives in San Anselmo with his wife and 3 children. He's an experienced as a physician and an epidemiologist, and he's a member of this community to guide the public health strategy for Marin. He has a medical degree from Temple and a master's degree from Harvard. And then finally, we have Dr. Brian Sue, who's a orthopedic surgeon that works and practices in Marin, and he's also on the Marin Healthcare District Board and chair of our COVID-19 task force. With that, take it away, Dr. Rutherford. And we will be having questions at the end, which you can chat to us if you'd like. We've also had some emailed to us as well, but go ahead and chat us your questions, and we have time for those at the end.
Very cool. Thank you. It's a pleasure to be in Marin this afternoon. All right. Good. So I just wanted to sort of start off. I'm going to talk for about 10 minutes about the current state of COVID-19 epidemiology. There's a long background story, which actually starts 6 months ago to the day when the Hubei Provincial Centers for Disease Control in China sent a message to the Chinese National Centers for Disease Control telling about an odd cluster of cases in the city of Wuhan, a large city in central China that had pneumonia and appeared to be associated with a wet market. Now, this has gotten a lot more complicated since then, with more than 10,500,000 deaths as of this morning. But I think the real telling thing is how it's gone so sideways in the United States. And this slide, I think, kind of captures where we are in terms of case rates in the U.S. versus the rest of the world. In the U.S., as of this morning, there's been there were more than 40,000 cases reported on June 29th, and in fact, there have been more than 40,000 cases reported each day in the U.S. for the last 4 days, which is well in excess of the peak back in early April. This is a part of this is a massive outbreak among younger people through the Sun Belt and into the West Coast, and big states like Texas and Florida have halted their reopening plans and are put the brakes on. And California, at least in some places, is going backwards. Imperial County, for instance, was recommended to go back to shelter in place. In a twist of fate, New York, New Jersey, and Connecticut have now mandated a 14-day quarantine period for travelers from a number of states, and today that California was added to that list. This map shows you what the counties in the U.S. These aren't actually counties; they're metropolitan parts of counties in the U.S. that have had increasing cases in the last 2 years. The last 2 weeks. So red is the worst. That's the biggest increases. You can see all down through here. Florida's almost all redded out. Here's in Houston, Corpus Christi, Port Arthur. All these areas have had major outbreaks with huge crushes on the systems. This is Maricopa County, where Phoenix is, and the surrounding areas, which have also had large outbreaks and are talking about exporting patients sending patients out of state for care. One of the many-ish things going on at the same time are lots and lots and lots of cases in the Latinx population, particularly in the poorer populations, the more densely housed, and living, at least here in the West, with lots of people in the same room and with easy transmission. This looks at these are national data, but they look at the counties with the proportion of Latino residents. And you can see here in the West, in the counties with more than 25% of Latino residents, Latinos, in fact, I'm sorry, in the West, counties with more than 25% of Latino residents have much higher case rates per capita than counties with fewer Latino residents. It's all part and parcel of it. Here we are at this very attractive bar in Texas, complete with stacks of Pabst Blue Ribbon beer. Not that I'm going to be snarky about that, but anyway, Pabst Blue Ribbon beer, complete with a roll up front. And this is the kind of place where there was transmission going on. This is on Union Street in San Francisco, and with no social distancing, no masks. Tough to wear masks while you're eating and drinking, that's for sure. If you look across California, these are data from the last 2 weeks per 100,000 population. The big hotspots have been in Imperial County, down here, for those of you working on your California geography still, down here in the far southeast. Kings County, the small county in here, which has 2 large state prisons in it. But the big counties right now with lots of growth are Lassen County, which there's a state prison there, and that's what accounts for it. Glenn County, and nobody knows why that's on this list. And then Marin, which is largely driven by, there are a lot of cases at San Quentin. There's an explosive outbreak at San Quentin. But aside from that, there are cases in Marin anyway. Here in California, there have been more than 200,000 cases and almost 6,000 deaths. As you can see in the US, while cases are trending upwards, the death rate is remaining relatively flat. Let me go back and show that to you. I didn't talk about it much, but see how fast cases are trending up in the US, but death rates are falling. This speaks to having either a big lag, this would be like a month lag to not have seen this translate into deaths yet, or much more likely, these are younger people who are less likely to die. Having said that, the ICUs in Houston are filled up with 20 to 40-year-olds. So what are the drivers of incident COVID cases in California? Well, there's community transmission coincident with lessening of restrictions. You can really see this in Southern California. But it's not just Southern California, it's the San Joaquin Valley as well, and to a certain extent, parts of the Bay Area like Contra Costa. It's not, hanging out at bars. These are backyard barbecues, they're birthday parties, they're family gatherings, they're funerals, they're church services. There are all sorts of things like that that are accounting for a lot of this transmission. There's also this phenomenon of essential workers from high density neighborhoods that are predominantly Latinx. We've seen that in all the Bay Area counties, including Marin and the Canal District of San Rafael. There are institutional outbreaks in prisons, penitentiaries, and in nursing homes in Santa Barbara County, which has had a number of home outbreaks. There are also 1,000 cases at Lompoc Federal Correctional Institution. On top of that, we have more testing, and we have more targeted testing. I can tell you, the state government is enamored of this, of keeping the proportion of positive tests low. That strikes me as something that can be very easily gamed. And I'm much more impressed when they have tested a whole neighborhood and then start to see declining proportions. For instance, in the Fruitvale area of Oakland in Alameda County, right now, they're running positivity rates of between 20 and 30%. This is a Latinx, poor, densely housed Latinx community. And then in Southern California, there's been a partial border reopening with Baja California. Baja California has had arguably, if not the worst, one of the worst COVID outbreaks in all of Latin America, with people dying in the corridors of hospitals, ambulances not picking people up because there's no place to take them, and Americans who live in northern Mexico, in that part of Mexico, who are a lot, and we're not, people who are both retirees and people with joint citizenship are coming back in droves to seek care in California. And we've had, I know of at least three large hospitals in Northern California, excuse me, who that are have patients from Imperial County in them. This shows you Bay Area wide. Trends are largely on the upswing, except in a few places. Or San Francisco's come down a little bit, Alameda's come down a little bit, but everybody else is going up. Here you can see this explosive growth in Marin. This includes San Quentin, much to Dr. Willis's chagrin, I'm sure. But it's, that's a ton of cases. And Bay Area wide, we've had about 25,000 cases, but only 500 deaths, which I think is quite remarkable. I mean, each death is a tragedy. Each death is someone who's left early, left families behind, unfinished business. But this should, by all rights, have been something closer to 1,500 or so deaths if you went by the national averages. So we've saved a number of lives here, in addition to the probably tens of thousands of lives that were saved by early sheltering in place. Now, on to you. So this is these are data off of your own website from Marin County, and these exclude San Quentin. And even with the exclusion of San Quentin, you can see this explosive growth, not explosive, but this growth during this period of time. This was the kind of the first period back here in late March, early April. Then you perk along, and now you have another period of growth. A lot of this, as I understand it, is in San Rafael. And this just kind of gives you some composite data. Here, these are case counts by, I guess these are zip codes. Here's San Rafael with 548 cases. That's far and away the most. It's also probably, I'm sure, this is the biggest city. The second most is maybe 25 here in Larkspur or whatever this is here. I'm sorry, 67 and 97 and 67 and all these numbers up here in Nevada. Okay, I'm sorry. Forgot about all those. And up here in Bolinas, only 10%. If that is in fact Bolinas, it probably isn't. This is Bolinas here. No, I'm sorry. Wherever Bolinas is on the map. So there have been 1,185 cases outside of San Quentin, with 784 recovered, 61 hospitalized, 18 deaths, and you're running at a 4% positivity rate. In San Quentin, as of this morning, there had been 1,085 cases. There are 42 patients who are hospitalized in community beds. We have a couple in the UCSF Parnassus ICU on ventilators. There's been one death, and the testing rates are running in the at the high end, like 42%. This gives you kind of age strata data for Marin. This is without including San Quentin. Here you can see hospitalizations at 50 to 64-year-olds and 65 to 79-year-olds are overrepresented among people hospitalized, but younger people here from 19 to even under 18, I'm sorry, even 18 and under, but people 19 to 34 really account for the bulk, and 35 to 49 account for the bulk of cases, just not the bulk of hospitalizations, nor the bulk of deaths. Okay. The state also has now, and through a website called calcat, calcat.ca.gov, puts up all the available models for as much good as that as those do. These are the models for Marin, and you can see they're crystal clear. Here we are today. You're either going to go, take a rocket ship to the moon. It's going to go up and down, or it's going to stay flat. Okay, take your choice here. So those are what your models say. Not particularly helpful, but I think this at least may recognize this light blue on the ensemble project may at least kind of recognize the up and down character of the San Quentin outbreak as long as they don't continue to bring susceptible inmates in. This is an interesting thing. There's a construct in epidemiology of the basic reproductive number or the effective reproductive number. The effective reproductive number is the number of people whom you can expect to be secondary cases for every primary case. So if there's if the effective reproductive number is 2, for instance, you would expect each case to infect 2 people and each one of those to infect 2 more people. So you get this sort of exponentiated growth. Anything over 1 is bad, right? And you want to be as close to 1 as possible. San Francisco is currently 1.06. Alameda and Santa Clara are 1.03. Contra Costa is 1.34. And Marin is 1.44. Again, this includes San Quentin data. Now, and finally, here's the problem, is that we're going to start getting tight on beds again. Beds are already tight in Southern California. In Northern California, I just saw the data for this afternoon for UCSF. We're running well below capacity in the ICUs, but we're taking patients from San Quentin. We're taking patients from Imperial County. Irvine is almost completely full. They've taken the bulk of the patients from Imperial County. So this shows you overall hospitalizations. These are non-ICU, these are ICU, and you can see these are both higher than at any point in time in California. This is the Bay Area, and you can see that we had these very high rates back here, these high hospitalization rates back here in mid-April. Those petered out, but are starting to come back up again, which is a combination of just the sheer volume of younger people who are infected, and they're showing up as cases, plus the occasional case in older people. There was an outbreak last Monday, for instance, not a week ago, last Monday, in a nursing home in Contra Costa with 148 cases. So the governor has put together a new system to keep watch on counties to make sure they're not opening too fast, that they're not kind of just letting business interests overwhelm the public health interests. So they created a variety of rubrics, which you can read here. So 14-day case rate of more than 100 per 100,000. We're in with a population of about 250,000. That would mean that you would have to have fewer than 25 cases over the last 14 days, and you're having tens of cases a day. So you're not there yet, but here, this is another way of looking at it. Also increased hospitalizations and limited hospital capacity. So if you don't meet all those criteria, you're placed on a watch list, which means you get a lot of, I don't know if it's desired or undesired oversight from the state. There are 3 Bay Area counties on this watch list: Contra Costa, Santa Clara, and Solano. And then there are also some pretty close-in counties like San Joaquin, Stanislaus that are on this, and then all the Southern California counties. Just to give you an idea, for each one of these counties on the state website, there's a little vignette. This one is Santa Clara, which has variance, which means the Board of Supervisors voted to let it out of the governor's shelter in place. Report says parallel to an increase in hospitalizations, parallel to a rise in community transmission. And then these are all the mediation things that the state's going to help them do. So I will stop there, and I'm going to hang around and happy to answer questions. Thank you very much. I hope I didn't steal all of Matt's slides.
Matt can just go faster through them. Thank you so much, Dr. Rutherford. And Matt, we're going to turn it right over to you.
Thank you. Thank you, Dr. Rutherford. I'll just go ahead and share my slides. Jennifer, I'm sharing content here. Do I have permission to do that?
You should be able to. So at the it
Now I
says
can. There
arrow.
we go.
Okay, great.
Thanks. So can you see that? So I'll just go quickly through just some of the, and thank you, Dr. Rutherford, for that super helpful summary and offering context of Marin within the region, the state, and the nation. I'm going to share with you just some of the data that you can find on our website at coronavirus.marinhhs.org. Our daily data is updated about 4 p.m. And we're having an increasing number of different metrics that we're tracking, and invite anyone in the community who's interested in watching this to go online, and if you have any observations or suggestions, you can reach out to COVID-19, our email, covid19@marincounty.org. This is our total number of cases that we've had in Marin County over time since the beginning of the pandemic. And it shows as the slope continues to increase, while our total hospitalizations and total deaths remain relatively flat. This is the total number of tests per day. What this shows is really a relatively dramatic increase in the numbers of tests that we've been able to perform on a daily basis. We have recognized right off this, from the start, that one of the most important tools available to us for understanding where the virus is flowing within our communities to guide our strategies has been testing. And you can see from, for the first month plus, we were really struggling to get testing online based on, national and state lack of supplies, essentially. But starting in May, we started having more and more testing resources. And now we have a much better sense of where transmission is occurring within our community, what are the activities associated with transmission, and where we need to really focus our strategies to reduce transmission through the intelligence that testing offers. You also see that there's increased numbers of positives associated with increased testing. Dr. Rutherford shared some of this, but I think what's important is the bottom donuts. If you look at the left-hand donuts there, it shows our total population, the race and ethnicity makeup of our population as a county as a whole at baseline, and then the number of within those groups that are been infected with COVID-19 or diagnosed with COVID-19. What this shows is the dramatic overrepresentation or disproportionate influence on our Hispanic and Latino community. 75% of our cases across the county are people who self-identify as Hispanic or Latino. We collect race and ethnicity data for every person that we test, and that's consistent with, but I think even a more remarkable dynamic in Marin County, consistent with what's being seen across the West and in California, but I think in Marin it's even more dramatic. This is, again, just available on our website, and it shows the distribution of cases, the number of cases in different communities. We really see West Marin is relatively spared. The majority of cases are along the 101 corridor where most of our residents live. This is a daily dashboard that is collected by the Chronicle, and it shows, just calling your attention to the hospitalization rates over the past 2 weeks, hospitalization numbers going from 6 to 15. So we have, a relatively small county, 3 hospitals, and so when we're looking at hospitalization numbers, it's usually bouncing between 0 and 10 up until just last week, and now we've started seeing more individuals in the hospital. Right now, we have 9 individuals hospitalized who are San Quentin inmates in our 3 hospitals. So the surge of cases in San Quentin is, fueling our case rates as a county, but is also contributing to our hospitalization rates. And then on the testing column there, you see that Marin and San Francisco are neck and neck in a friendly competition to see how much testing we can do, because I think we share the same sort of understanding that in the absence of widespread testing, it's really difficult to determine, obviously at an individual level, who's infected, who isn't, but from a public health standpoint, on a population level, to really guide our strategies and know where the virus is flowing. And this is shows that the proportion of, the number of cases over time in Marin County has dramatically increased. As Dr. Rutherford said, by including San Quentin, it is having one of the largest outbreaks in any prison across the nation, in fact, and the largest outbreak in the state. It has really just of late, just in the past 2 weeks, significantly skewed our data. So just to get into that a little bit, as of this afternoon, there were 1,080 cases in San Quentin. About 900 of them were diagnosed just in the past 2 weeks. So we are now at that point, almost of an equilibrium point between the total number of cases in Marin County total thus far from the beginning of the pandemic, as there have been in San Quentin alone just in the past 3 weeks. This is an important observation, I think, as I think about what's happening in Marin County. This is the number of patients who have been hospitalized or died who have been diagnosed with COVID-19 at different time intervals since the beginning. And what the top column, the top row there shows is from March through mid-April, we had 42 total patients who were either hospitalized or died, which was 17% of all of our cases were hospitalized and 8% died. And the average age of the cases at that time was 55 years. Now going to that mid-May to present row, what we see there is that only 3% of our total cases have been hospitalized, with less than one half of 1% have passed away. And correspondingly, the average age of the cases has decreased to about 34 years. And so, as Dr. Rutherford shared, that pattern is happening across the nation, where the average age of cases is decreasing, or the number of cases among young people is increasing. But there's also a decrease in the mortality rates. We're seeing that play out here in our own county. And here's another way of reflecting that. This shows for different age groups, the proportion of people who have been hospitalized and the proportion of people who have died. And what this shows is that on the left side with the blue, you see 22% of individuals aged 65 to 79 who are infected with COVID-19 or diagnosed with COVID-19 have been hospitalized, whereas people below age 50, it's been very low, less than 3% hospitalization rate. And all of our deaths have been among individuals aged 64 or greater. This is also, I think, one of the most telling and precise descriptions of the epidemiology in Marin. It's thanks to our wonderful epidemiology team that we're able to provide this kind of information. What this shows is, as you saw on the first slide, we're seeing increased transmission, increased rates in Marin County across the board. And this tells me, as a public health officer, that there's a relatively precise driver of that particular, that dynamic of increased transmission. It is basically in younger patients who are Latinx. Almost all of the total increase, 90% of the total increase in cases are among people who are Hispanic or Latino, younger than age 64. Those dotted lines on the bottom represent people who are white, which is obviously the vast majority of our particular county, about 80% of our residents, where the rates have not changed very much since April. And really the driver is in a particular dynamic in a particular group, especially those that have been essential frontline workers from the beginning of the shelter in place, kind of the backbone of our economy in many ways, being infected out in the community, on the front lines, maybe being infected within their workplace, bringing the infection back into homes where it's amplified, where people are densely living together, sometimes 5 to 10 per household in 1 or 2 bedrooms. And that just is a very effective amplifier of the transmission in the cases, and we see the numbers reflecting. Fortunately, I think largely because they are working and well enough to be working and younger, the hospitalization rates for that group are not as high, but we would be in trouble if these were, older residents or people that had or other medical conditions. And this just shows our hospitalization rates per case have declined as our case rates have increased. I just want to offer a little bit of perspective on one of the ways that we're seeing this being driven within Marin. This is an outbreak that was made publicized, and really served as an example of what we're seeing in workplace transmission. This is a Marin Sanitary Service outbreak where we had, through our community level testing, found one individual who identified as that as their workplace when they were tested. We then were able to go and do a little more widespread testing within that setting, and saw 5 more cases. And then we've traveled to that site with a mobile testing operation and did I think over 288 tests, and found that there were 37 more cases identified among workers at that facility, based on transmission that had occurred probably within that workplace. And this is one of the patterns we're seeing, is that people may be quite vigilant when they're out interfacing with the public in terms of wearing PPE, maintaining physical distancing. And then there may be a more relaxed and more casual approach, because people may not have symptoms, and they may assume that when they're on break and they're in the break room together, they may not practice all those precautions. And so more widespread spread within the workplace. And then each of those individuals, you imagine bringing that back to a household within the 5 to 10 others, that's a significant driver of community-wide transmission in numbers. I'm just going to get now into the elements of our shelter in place here in Marin. If you remember, we were among the first counties in the nation to issue a shelter in place when we were first seeing spikes in cases in March. We joined with 6 other Bay Area counties, and these were the elements. These were the businesses that were allowed to remain online during that first shelter in place, based on the fact that they were deemed essential, things that we needed to live. For example, access to healthcare, pharmacies, grocers, access to food, etc. Then, after having flattened the curve through that relatively restrictive and aggressive shelter in place regionally, on May 4th, we started bringing different sectors back online. And then we've been taking gradual and sequential steps every 2 weeks since that point. And these are I'm just listed here. I won't go through all of them. The elements that came online at different intervals. On June 5th, we brought back outdoor faith-based and cultural ceremonies of people up to 100. And on June 12th, indoor retail started, which is a big step forward. We took a little step on June 19th to allow social bubbles of cohorts up to 12, acknowledging that the only driver of this isn't just our regaining our sort of economic security and bringing business back online, but providing some guardrails for how we might relate within our friendships, within our social groups, in ways that are safe. And the recommendation is choosing a cohort of up to 12 people to sort of be that social bubble, that protected group where most of your social interactions are really limited to that group, and you're interacting together safely out of doors with facial covering. Because up to that point, there had been an expectation that you really weren't relating socially with anyone outside of your immediate household. And we recognized that was something that was actually, after more than 100 days of sheltering in place, people were starting to gather anyway, but we're doing it in much less safe ways. So we thought by introducing this concept of the social bubble was a way of defining how that might be conducted safely. And I think that's an important principle. And then importantly, June 29th, we made a decision on Friday, June 29th just being this past Monday, yesterday. On Friday, we decided not to actually move forward with most of the elements we planned to move forward on based on the surges in cases, some of which Dr. Rutherford referred to. San Francisco and Contra Costa also chose to delay reopening based on numbers they were seeing. We had also intended to and did not move forward with moving hotels, motels, and short-term rentals, personal services like body art, nail salons, estheticians, have been delayed, and gyms and fitness studios had been online for coming on June 29th, but are going to have to wait while we let the dust settle around what's happened both with San Quentin and with our own transmission within our community, so that we're not having to go backwards. You know, our decision is to move forward more slowly, and so that we don't have to make those more difficult decisions to actually close things down that have already opened, which is occurring in some other countries. This is, one of the ways that, those decisions are informed is by looking at history. You know, those who can't remember the past are condemned to repeat it. And this is 1918 flu pandemic. And what they saw was, they had felt self-congratulatory after flattening that first wave and that first curve. They may not have recognized that there was several waves ahead of them. And we don't want to make that same mistake. We don't want to be falsely reassured by the success that we had in our first shelter in place, which was quite successful in flattening the curve. And I think we're already seeing that we're entering really a second wave for us that is already eclipsing what we had experienced in that first wave. So which future will we choose? And this is, I'll end with this, which is sort of an invitation for everyone in our community to participate in the solution here. This is a graph that's specific to Marin. This is some of the modeling that's been done for Marin. That bottom dotted line there shows our total licensed bed across all of our hospitals, which is 420. That's our total beds, not just our ICU beds or COVID dedicated beds or negative pressure beds. This is B fluid. Every single bed we're occupied. And what it shows is that at different levels of how vigilant we are in those self measures, those non-pharmacologic interventions, these are things like physical distancing, covering our face, not going to work when you're sick, washing our hands frequently. The effectiveness collectively across the community, how well we do those things, is the most important determinant of what our experience will be in terms of surges into our hospitals over the next few months. And it's extraordinarily sensitive to how well we do these things. So, for example, if you look at if we're only 30 to 40% effective in those interventions, that's that blue curve there at the top. We would see, this model predicts that we would see up to 1,600 hospitalizations in August. Whereas if we're 50 to 60% effective, so even just a fractional more, effective in those and more vigilant, that purple line, that lower purple line, shows that we would still stay within our total hospital capacity. And if we were even 70% effective, it's closer to that flat line. And so the invitation, I think, for all of us is to be at least 70% effective in all of our collective behaviors. It's not rocket science, it's simple stuff. We're talking about making sure you're maintaining physical distancing, covering your face, frequent hand washing, knowing your risk. Just because it's open and allowed doesn't mean it's safe. And knowing your own risk factors, knowing your own vulnerability, and maybe choosing to remain sheltered as business sectors reopen if you're at higher risk for poor outcomes. And I know there's going to be some questions, and we'll get a chance to answer those. So just because so much of this relies on our own behavior, I want to just offer sort of a model for how to think about this. Infection occurs when someone receives an infectious dose. You can imagine that we think of it as about 1,000 virus particles to ingest to become infected. Right? That can happen all at once or over a period of time, over a period of minutes or even hours. Factors that determine that viral dose are the duration of exposure to someone who may be infected, the proximity, and whether or not they're wearing facial covering, whether it's happening indoors or outdoors, and then the possibility that it may have settled on the surface that you might touch. So that's what's informing our decisions about what reopens or what doesn't at a given period of time. That's one of the reasons we've delayed something like a nail salon or some of the body art, because you're having much closer interaction, more intimate interaction, massage for a longer period of time, where that duration is longer and the proximity is longer. So there's a higher risk of infection compared to, say, a cashier in a grocery store where there's a more brief encounter that can be accomplished over a 6-foot so over 6 foot distance. And then one of the principles is that we're moving things outside as much as possible. So we're allowing outdoor faith-based gatherings, not allowing indoor faith-based gatherings because outdoors is safer. So this is it. How do we reopen safely? How do we safely continue to reopen, knowing the virus is part of our environment? We do it carefully. We do it together. We optimize those self-measures, right? Which future will we choose? Moving it outside as much as possible. We recognize our own risk. We're following the data. We have to remain adaptive and flexible, and we made a last-minute decision to not move forward with things we had planned to on Monday. And then we have to rethink our assumptions about how things are done in every sector, including schools, which has been an active recent conversation. These are some of the resources. Obviously, this is a really challenging time for everyone. And I just wanted to flag some of the resources within Marin Health for people who may need support, may need counseling, might need mental health support, or healthcare. These slides will be shared so you can dig into these more. There's also some podcasts that have been offered by Marin Health, healing podcasts. Thank you, and we can do it. There's my 10-year-old at the Rosie the Riveter Museum, reminding us that we've got this, we can do it. Thank you.
Oh, thank you so much, Dr. Willis. We're going to very quickly turn it over to Dr. Brian Sue from the Marin Healthcare District Board. I know we've got a number of questions, and we are going to try to, if people are willing, go a little bit past 6:30 because we got started a little late. So take it away, Dr. Sue.
Sure, I'm just going to wait to allow to be the presenter. And it looks like I'm able to. You guys can see this okay?
Yep.
Okay. So in the first week of April, the Healthcare District Board declared a state of emergency, and we voted to commit district funds for use during the epidemic to ensure the health and wellness of our community. The district board established a COVID-19 task force, which I've had the privilege of sharing. And I myself, I'm a healthcare district board member, and I'm the medical director of spine surgery at the health center. So needless to say, I've had to surround myself by much smarter people in the field of COVID, which include other members of the task force. That's Dr. Naidu, who's the medical director of pain management. He also worked for the World Health Organization during SARS. Dr. Rubin's an ER doc. Greg Tolliver's chief of infectious disease. Matt Willis, who's our fearless leader, public health officer, and Lee DeMonico, who's the CEO of the medical center and healthcare district. After this was established, we had 5 meetings or so where we collected what we thought were the most important funding opportunities. We started with 15 items, we pared them down to 4, and ultimately in May 7th, we approved $942,000 in funding for these separate projects, and this is in conjunction with Health and Human Services as well as with Marin Health Medical Network. So I'll briefly go over them. First is money for housing COVID positive patients who cannot self-isolate because they live in high congregate housing, and for COVID negative patients who work at high risk jobs like skilled nursing facilities, et cetera, where they might be able to contract COVID. The next is income replacement. Sometimes COVID positive patients, they need to self-isolate, but they don't self-isolate because they rely heavily on consistent income. So this project is meant to essentially pay people to stay home if they're COVID positive. Next are kind of these kits that we put together. These kits are living in our ERs, living in our physician offices. So each kit contains a portable pulse oximeter. That's something you put on your finger to tell you what your oxygenation status is, a thermometer, surgical mask, cleaning supplies. These are dispensed to patients that are COVID positive or suspected. When you're COVID positive, you don't have to go to the hospital unless you meet certain criteria. And one of the best criterion is your oxygen saturation in your blood, which is measured simply using a pulse ox. And as many patients will tell you, including Matt, when he had COVID, pulse oximeter is really the telling factor for when you should be seen at the hospital or present to the ER. These kits are dispensed and then returned. And most importantly, most of the funding actually went to 2 full-time mobile testing units targeted towards high-risk areas, as well as skilled nursing facilities, residential care facilities. At some places that they've tested, 80% have been positive. At some skilled nursing facilities, at almost all of them, at least one resident was positive, 2 to 6 staff members were positive. In those situations, it's almost always the staff member bringing it into the skilled nursing facility. So these are 2 full-time staffed by medical director, Dr. Liz Lowe, with the assistance of Dr. Irene Tepper, with administrators. They work with Health and Human Services to target and trace positive cases. So the task force will continue to kind of evaluate the efficacy of these 4 things. There's limited funding, obviously. In fact, number 1 and 2 funding has already run out. While there may be more funding, the funds of the district are limited, so we're looking at other people to step up. But it's been a privilege to kind of head the task force, and I'm hoping that through Matt's leadership, we'll continue to weather this. Thank you.
Excellent. Thank you so much, Brian. Okay, Dr. Su, now we're going to move over to questions, and we're going to do this very quickly to try to get through as many as we can. So Dr. Willis, can you tell people where they can get free testing?
There's a testing tab, and there's basically two sites that there's just a link you can click on, and it allows you to establish a time for your test where you would come in and obtain free testing at one of those 2 sites. The sites are located, one's near the Civic Center and one's near the canal area of Centerville.
Okay.
And I should say that's public health free testing. Clearly, to protect that resource as much as we can for people who don't have an alternative, I would say start with your medical provider.
Excellent idea. Yeah, we really do need to save that resource if we can. Okay, we've gotten a lot of questions about San Quentin, so I'm going to try to bundle some of them together. Basically, people are wondering about contact tracing at San Quentin and isolation of workers, and are asymptomatic, apparently healthy workers still coming and going at will?
Yes, so the federal judge ordered that all San Quentin staff be tested, and that relates to the fact that healthcare within California Department of Corrections and Rehabilitation was moved into a federal receivership a few years ago, when it was recognized that CDCR was not able to really mobilize the highest available standard of care. And so that has been one of the levers that we've had available to us to ensure that the outbreak response is moving forward. So the testing now is being advanced on a regular basis through the federal receivership, and it's, as you can imagine, it's quite an operation. They have 1,800 employees, and they're being tested every 2 weeks. And we're working. Our relationship as Marin County is one of, unfortunately and sometimes frustratingly on the margins of what's occurring there at the facility. We are offering advice and counsel, and in some situations offering equipment when they need PPE, for example, gowns for testing. They were short, and we were able to supply them that. But we're just trying to make sure that they're able to sort of determine what the best practices are for an outbreak management like this. Is a obviously very complex outbreak that's moving very rapidly. And yes, there's the staff are being tested, and the strategy is to remove positive staff who are positive in testing, isolate them, and then retest on a regular basis the staff, because there's a presumption of ongoing exposures.
Okay, another one on San Quentin. There's somebody who lives in San Quentin Village, and they're concerned that the small little post office there, which everybody gets their mail at, is being used by the guards as well. So the guards from San Quentin are going into this post office as our neighborhood residents, and there's concern that the staff and the residents of San Quentin Village, there might be some exposure. And could there be, or are there any safety measures or protocols that are going to be put in place, such as possibly staggering visits to the post office or additional sanitizing to ensure that transmission is not happening there?
Yeah, I mean, I think this is an example of we need to presume that the virus is throughout our community. When you are venturing out of your home, whether it's to go to the post office or go to the grocery store, or any of the other activities that are becoming more available as we reopen, it's really important to, in every interaction, to presume that you may be exposed to the virus, and that's true throughout the Bay Area. We have over 1,000 cases just within our community. Aside from San Quentin. So yes, there's more activity in San Quentin, but I think that's, for visiting the post office there, if you're covering your face, if you're practicing physical distancing, if you're washing your hands, that's the same advice that I would offer anyone visiting any other post office across Marin.
Okay, so there's a question, are the cases of COVID-19 occurring among the San Quentin population being counted the same way as non-inmate COVID-19 cases when evaluating if Marin is meeting the state and county's criteria for reopening?
Yeah, it's both and. So, Dr. Rutherford, shared some of the slides that show Marin County rates are like 3 times, over the past 2 weeks, any other county in the region. And that's because when you add San Quentin, and literally, we've had in the past 2 weeks, almost as many cases in San Quentin as we had over the rest of the period for the rest of the county combined. And so that obviously, it makes the models really hard to predict, what we're actually experiencing in our community. Obviously, we value the health of inmates. We recognize that they are a part of our county, but they are also jurisdictionally separate and epidemiologically separate. The denominator of total risk in that setting is 3,500 inmates. And so for me as a public health officer trying to make policy decisions about the shelter in place, where we're going to offer our testing strategies, where do we need to be dialing into our cities and towns, I need to be able to see the signal and the noise need to be separated. So I need to be able to see what's happening within the county outside of San Quentin, as well as what's happening in San Quentin. So the answer is we look at both of them separately, and then we also look at them together for different purposes.
Okay. Case numbers in Marin have increased significantly in the 0 to 18-year-old age group in recent weeks. This is concerning. Can we get more specific stats for the age of the kids? Are they mostly preschoolers, school-age, teenagers? Also, are the kids testing positive mostly symptomatic, or are they asymptomatic of being found through contact tracing?
Yeah, the short answer is that most of the children that are diagnosed are part of that household transmission I talked about. An essential worker might bring it back to their family. And the children will be tested. It's not unusual when I look at the positive results that come through on any given day to see the last name over and over again, 3 or 4 of the same last name, and then again, because those are families who came in to get tested at once. Many are asymptomatic, and that's where where we're seeing the children. We have had, I think, 1 child total hospitalized in Marin County who was hospitalized very briefly, but probably not a COVID-19 related incident, but since the beginning of the pandemic in Marin.
How often are grocery workers being tested, and can that be mandated? I understand that, for example, like United and Goodard, some of the markets have taken up the county's offer on testing and others haven't. So is there, how many of our grocery store workers have been tested, and can testing for those workers be mandated?
Yeah, we've just started collecting occupational history and it's voluntary if people want to offer that when they're tested. I would estimate, say, 150 grocery workers have been tested in Marin, or who people have identified as being grocery workers when they've been tested. Our recommendation is that if they get tested monthly, along with anyone else who's in sort of a public-facing job, and that's one of the reasons we have these public free testing sites available. It is not mandatory. Some employers are requiring it, and we offer the employees, a certification that they've had the testing, what the result is. If there's an outbreak at a workplace, that's a different dynamic, and we do in those cases strongly recommend testing. We'll often visit that workplace with our mobile testing facility to make sure that everyone's all tested at the same time. We do that serially, weekly, until we're not seeing any more activity. in that setting, like we did with Marin Sanitary.
Okay. Why are hair salons still opening this week? The contact time and close proximity is similar to personal services that were delayed.
Yeah, I mean, the hair salons were categorized differently, even in the eyes of the state, in terms of the risk. And our hair salons have done a lot of work to modify their practice so that they can do it more safely. And this was a sector that had been prepared, I think, weeks in advance to come back online. And some of this is also just the risk-based, the decision making in terms of what are the, as the longer we go, keeping a certain sector closed, the more essential it is deemed to be by people who have been deprived of that service. And that was one of the reasons why the hair salons came back online.
Okay, what about indoor dining? Though it's possible to space patrons apart, they obviously can't wear masks, which puts the restaurant workers at greater risk.
Indoor face, why isn't, sorry.
Why indoor dining? Why is that
Why-
being resumed? Because that's going to put the workers at much greater risk.
Well, indoor dining, when we talk about indoor dining, you have to visualize, you're not talking about the restaurant that you would normally visualize. These are settings that have been altered significantly. In fact, one of the reasons we moved forward with outdoor dining first was to allow restaurants to begin to have business. And the tables need to be, the closest anyone can be is 6 feet apart. So there's far fewer tables. In fact, many of our restaurants just feel as though it's not possible for them to reopen with the restrictions that we've placed on how indoor dining can occur safely. And it's like any other business, we really need to rely on our business owners and our consumers to be practicing those safe practices of covering our face, physical distancing, hand washing. And it's not just indoor dining, it's every other sector, every other business. Through the Marin Recovers group, which has been our engine of rebuilding and coming back online and making sure it can be done safely. There's been strategies and standards established for every single sector, including restaurants, and we're relying on them to apply those.
Okay. As one provider told a friend, it's not a matter of who will get it, it's a matter of when you will get it. We're all going to get infected at some point, but obviously to varying degrees. How accurate is that statement in your opinion?
Yeah, may I take that one?
Yeah, please.
Yes.
Yes.
That's high for he's got to save his voice, right?
Thank you.
That's highly inaccurate. That's highly inaccurate. There's nothing that says everybody has to get this. It's not written. It's not preordained. It's relatively straightforward to prevent this. You just have to be careful and think. Okay. That means wearing masks when you're outside, not congregating, staying home if you're sick, and washing your hands. Okay. Period. That's it.
Okay. Excellent. And a follow-up for you on this one. What's your level of trust in the COVID-19 data being reported by counties, states, the United States overall, and globally?
It's as good as it gets, right? We're on top of this pretty much. There's a lot of undiagnosed cases, which obviously don't get reported because they're undiagnosed. And that's a kind of crapshoot guessing what that is. CDC took a wild guess that it was 10-1. I think it's closer to probably 2.5 to 5 to 1.
Okay. And I guess this one's for Matt. Is contact tracing helping us to understand the source of the recent spread? And I do think that you've illustrated a couple of examples where that has, but how well is contact tracing working?
Yeah, it's super. We get a lot of insights into the transmission through contact tracing. I mean, it's disappointing sometimes when our contact tracing finds that the source was like a sleepover. We find indoor parties as another example. You get a case, do the interview, and turned out that the contact tracing reveals that there's been transmission within a completely avoidable dynamic where it was just poor choices. People traveling together in a car without their face covering from other households. Those kinds of gatherings that we're trying to prevent by offering those guidelines of the social bubbles, and then also showing that the really challenging dynamic of essential workers coming back into a household where it's almost impossible to physically distance, impossible to be isolated from families, and seeing that as one of the primary drivers.
And I will add, that's part of why the healthcare district has put money into trying to make that housing possible to allow people to house outside of the house if they are tested positive or at high risk. And is there additional funding available for that? Do you know? I think FEMA is supporting a lot of that. Yes.
Yeah, so it's worth just spending a moment on that, because that's a really key strategy, is that we need to make sure that people who are infected are separated from people who aren't. That's kind of our main thing. And so when an essential worker who is positive comes back into a household and infects the rest of the house, we have failed to do that. And the only way to prevent that from happening is to have that person have an alternative place to live for a period of time and offer them income so they don't have to go to work, especially if they're relying on daily income to make ends meet. So that strategy of funding housing and funding income replacement is really fundamental to our ability to manage this outbreak collectively across the community. And so Marin Health has stepped up, offered some funding for that. We sort of did it as a pilot to sort of do the proof of concept, and that money is being well spent, and we're going to need more of it. And we're now using FEMA and appealing to other organizations for continuing to support that essential function.
Okay, we've had a couple of questions about the safety of children returning to school in the fall. So given the slide on increased risk of exposure to viral particles in inside environments over long periods of time, as well as what another person pointed out is the laxness that people have had in terms of adhering to some of the social distancing and mask measures, how can it be safe for kids to return to school?
Well, yeah, I mean, tomorrow's KQED forum is all about that. So just tune in. And I got this stuck with saying it's not safe, which I don't believe at all. I think it's actually kind of safe. I think it's pretty safe for elementary school kids. A lot of countries have been doing this. We haven't seen any school outbreaks in elementary schools. The risk is in high schools and in middle schools. There's a physiologic reason that has to do with the number of receptors per gram of tissue. It's much lower in younger children than it is in adolescents. Adolescents look like adults. And, the places where we're going to have outbreaks are high schools. And those kids are big enough to understand they have to keep their masks on. If we can do that, I mean, I know I've been working with a couple of school districts, and you can work out a way to keep them in sort of smaller groups, smaller cohorts. I think you could see your way, through a school year until we get vaccine.
Great, thank you. Dr. Willis, did you want to add anything to that?
No.
Okay.
I was just trying to take the load off of him for a little bit here.
Yeah, I think that's great. And then we've had a couple of questions about whether or not some of these prevention measures, like wearing the mask, can they be enforced? Are there going to be any enforcement actions to make sure these sorts of things are happening?
That's yours.
Yeah, that's Dr. Willis.
Yeah, we did issue an order, a mandatory face covering order, and it was basically any shared indoor setting as well as any outdoor setting where you might be in close proximity to others. Really, the only setting where you weren't required to wear a mask is if you're kind of alone outdoors, or if you're exercising and moving through space quickly. Running, jogging on your bike. And then the state now last week sort of offered very similar order, but extended the age group. We had really only limited or required children above age 12 to wear masks. The state now says above age 2. And so there's even a more rigorous, so there's basically 2 layers of mandatory facial covering in Marin County. There's the one, the county order, and sort of augmented by what the state is offering. And that's, I think ultimately, like so much of this though, there's the law. I mean, there's the order, which is the strongest language we can offer from a public health standpoint. But what we know is at the end of the day, largely voluntary compliance, because these are really difficult to police at the population-wide level when it's something everyone should be doing all the time. And so here, first of all, internalization of the value of this within our own individual behavior, and then peer-to-peer pressure, the way we had with smoking, when you were telling someone that they weren't welcome to smoke near you, when you sort of recognize that you have a right to having the person near you cover their face, because it is for your benefit that they would be covering their face. I wear my mask for you, you wear your mask for me, primarily. And the more that we can sort of understand that as a matter of community responsibility and social welfare, I think ultimately that's going to be the driver of compliance and adherence to this more than law enforcement.
Okay, I do want to be very respectful of the time of our panelists tonight, and we did say that we would end at 6:30. So how about one last question, if you're all willing?
Fire away.
All right. Will you continue reopening on the 2 weeks interval schedule? Can we look to see more sectors opening on July 13th?
George, what? No, I'm just kidding. I'll take it.
Yeah, sure. Yeah, we're good. We're good. Yeah.
Yeah, no, I think we're gonna the 2 weeks. It's all based on the data. You know, I think that this virus is in real life. You know, it's a piece of it's part of nature, and we are forecasting this. But we also don't have a crystal ball, and we really do need to be humble in what we can meaningfully predict and what we just have to observe. And I think we will move. You know, we've been moving forward, and we'll continue to move forward where we feel like there's room to take that action. Right now, we're seeing dramatic increases in cases. We have this wild card of now San Quentin coming up and doubling our case rates, which is just within 2 weeks. And so it's really too early for me responsibly to say what we're going to do Friday until we really have a better sense of the trajectory of this. So the 2 week interval made sense because that's the incubation period of the virus. But I think we've made a good decision to pause where we are right now and really need to take a close look at the data for the next few days to make the next decision.
Okay. Again, I want to thank our panelists so much for participating in this health education seminar today. I will let folks know that we didn't get to all of your questions, but I do have all of the questions, and we will work on getting them answered, and we will work on posting those answers on the Healthcare District website. So I might be sending some more questions your way, Dr. Willis, Dr. Rutherford, and Dr. Sue. And again, thank you so much for participating. This event has been recorded, so people can look at our Healthcare District website for a link to this recording. And given the high level of interest in this, we may plan on doing a future educational seminar on COVID as well, since this is really the topic of the day. So thank you all. Be safe, wear your masks, wash your hands, practice good social distancing. Have a great evening.